It's 8 o'clock.
It's perfect.
Welcome all of you to the 68th live webinar on orthopedic principles. Good evening to everyone from India and good morning to all those who are listening from Mexico. Today, our guest of honor is Dr. Michell from Mexico City, Mexico. Dr. Rui was appointed as attending physician at the National Institute of Rehabilitation in Mexico after finishing a sports medicine fellowship at the Plano Orthopedic and Sports Medicine Center in the United States. He completed a shoulder and fellowship at the same institute and the Arthroscopic Association of North America Traveling Fellowship. He's a founding partner and attending physician at the Traumatología Deportiva de Mexico, where he also is the co-director of the Sports Medicine and Shoulder and Elbow Surgery Fellowship. He serves as the associate editor of the Acta Ortopedica Mexicana and Shoulder and Elbow, and as an editorial board member of the Orthopedic Journal of Sports Medicine and Sports Medicine and Arthroscopy Review. His current research interests are biochemical mechanisms of tendon injury of the shoulder and bone, complex shoulder reconstruction, and elbow ligament reconstruction. He's the current president of the Mexican Society of Shoulder and Elbow Surgery. So today it's my honor to introduce you to Dr. Michell Ruiz-Suarez from Mexico City, Mexico. Over to you, Dr. Michell.
Thank you very much for the invitation. It's a real honor to have this invitation. And it's going to be my pleasure to share with you some of the concepts that I've been working on the last few years on lateral elbow pain. I want to add a subtitle for this presentation in particular, because not everything is lateral elbow tendinopathy, and that is what is going to focus on this presentation. So first, we have to know that the elbow is a very complex joint because of many things. First of all, because of its muscle anatomy. In this case, we're going to focus on the lateral side, that we know that the lateral mass of the elbow is compounded by the extensor and supinator muscles. So these movements, these conjugated movements, are very important for the daily life activities. And although we have also a flexor pronator medial mass, we're not going to touch on those regions just for the sake of this presentation. And it's very important also to acknowledge the nerve anatomy. 3 of the main nerves of the upper limb go through very near the bone structures. We can have the radial nerve. We also have the ulnar nerve, and of course, we have the median nerve. But at the same time, these 3 main nerves branch around the elbow and give a sensation and also a motor function to very specific muscles around the elbow, and that is what is going to be focused on this presentation. And some things that are not very well acknowledged, and it's very important to know, is that the lateral ligament complex is compounded mainly by 3 different elements. By what we know properly as the radial collateral ligament, that will be like the proper lateral collateral ligament that surprisingly in this case does not play a significant role in the function. For the sake of stability, we are going to focus in this band that traverses obliquely the elbow, and that is called the lateral ulnar collateral ligament. That is a very important stabilizing ligament of the elbow, and of course the annular ligament that keeps the proximal radio-ulnar joint stable and functional. And what is very curious about the elbow is that the elbow is the most congruent joint of the body. We can say that it's almost ultra congruent joint, and we can see here in this particular slice that the distal humerus is perfectly congruent with two bones, with the concavity of the radial head and the convexity and concavity of the proximal ulna that comprises the coronoid and the sigmoid fossa. So just by taking a look at this picture, we can also see that bone deficiencies may cause significant problems for the stability of this joint. But let us start with the most frequent cause of lateral elbow pain, and that is known as lateral tendinopathy. As we are stating here, it is by far the most common cause of lateral elbow pain, but it's very important to acknowledge that it is not the only one. So due to these causes, it's very important to be very specific with a history. We have to know the age of the patient, the occupation, if they practice some sport, and what is their level of activity into that sport. And the physical exam is paramount for confirming or having a differential diagnosis of lateral elbow pain. We know that lateral tendinopathy was first described almost 150 years ago by Major in the UK, and it was first described as tennis tendinitis. And since then, it has stuck like that term as tennis elbow since then. And that it can be a little bit confusing, particularly for the lay public, since most of them will go to the physician and they say that they have this tennis elbow, and the first answer that they will do is, how is that? Because I don't play tennis. So it's better to shift that term and focus in what is called the lateral tendinopathy. We can also find tendinopathy on the middle side of the elbow, but by far the lateral side is more frequent. And it has been described to be in a ratio of 4:1, and some articles even describe it to be in a frequency ratio of 7:1, being the lateral side, as we can see, far more frequent affected, the lateral in comparison to the middle side. And we now know that it is not an acute inflammation, but it's rather a chronic inflammation. And when the patient most of the times goes to our office, we have to know that we are not going to treat these patients if they are acutely inflamed, because most of the treatments in this phase are not going to be successful. In the 70s, Dr. Michell described the findings as an angiofibroblastic hyperplasia, but there has been some findings from the microscopic point of view that have changed this, the findings very subtle, and now we call it as a tendinosis, an angiofibroblastic tendinosis. We know that lateral tendinopathy is an overuse injury, and so we can find it in athletes that use their elbow, particularly in amateur athletes that have some lack of good technique for practicing their sport, mainly tennis, particularly with a backhand strike. And also in some workers that tend to use very frequently their elbows, as we can see in carpenters. It afflicts mainly the extensor carpi radialis brevis muscle tendon unit, but it's not the only tendon that is going to be afflicted, particularly in chronic stages, because although at the starting point of this pathology, the ECRB may be the only tendon, with the chronicity, it may extend proximally and distally and afflict the rest of the extensor muscles of the forearm and also the supinator muscles of the forearm. as we say here, it's only acute inflammation found in the first 2 weeks of when the patient is beginning to experiment the symptoms. And if by chance they get to be symptom-free after 2 weeks, and after some weeks or months, they again have these pain on the lateral side of the elbow, well, maybe in the first 2 weeks of the second event, maybe we can find again these acute findings of inflammation. But from then on, we are not going to find these classic features of acute inflammation, and we're going to find this chronic tendinosis that is going to affect the function of the elbow, of the wrist, and probably sometimes of the hand. There are very specific signs for identifying lateral tendinopathy, and I use these 3 tests routinely in my office just to rule out or to confirm the presence of lateral tendinopathy. The first one will be the Mills test, that it comprises of palpating the lateral epicondyle with our thumb while we passively pronate the forearm and flex the wrist and extend the elbow. It's the patients that have true lateral tendinopathy are going to experience very specific pain in this point. The second test that I use is a Motley test. In this case, we ask the patient to extend the elbow, and with a wrist in a very slight flexion and the fingers also volarly flexed, we ask the patient to extend the middle finger against our force, and they are also going to experiment very specific pain in the lateral epicondyle. And finally, the Cousin test, that it comprises of a resisted wrist extension with the elbow in full extension and very slight radial wrist inclination with a hand in a fisted position. So none of this by itself is 100% sensitive for lateral tendinopathy. But if we take these 3 physical exam tests at the same time, we can confirm the presence or not of lateral tendinopathy. But of course, then it comes trouble. What happens if the patient still is complaining about lateral elbow pain and our previous physical exam tests are like not completely confirmatory? Then we will have to take into consideration the presence of all these differential diagnoses that we have to rule out just to make sure what the patient is experimenting. We have to rule out cervical radiculopathy, also the presence of radial tunnel syndrome, radiocapitellar arthritis, the presence of a posterolateral plica, posterolateral rotatory instability, and something that is becoming more and more frequent in my practice, that is the finding of lateral antebrachial cutaneous nerve compression or irritation. And we're going to dig in all of these differential diagnoses following this slide. So, as we said, cervical radiculopathy has very specific signs that we have to take into consideration for the differential diagnosis of lateral elbow pain. So the patient is going to experiment pain in C5 and C6 dermatomes. And as we can see here, this dermatome is located along the radial side of the forearm, including the thumb and the index finger. But also it may affect the C6 and T1 myotome, and from a motor point of view. Something that I always look in my patients is these patients that have lateral elbow pain, but due to cervical radiculopathy, will most frequently present pain, lateral elbow pain, on both elbows simultaneously. So a patient that is presenting to your office with simultaneous lateral elbow pain, you do not have to think as a first diagnosis as lateral tendinopathy. You will have to think first that it's probably a cervical pathology. And another frequent presentation at the office is that patient that has simultaneous lateral and medial pain of the elbow. In those cases, definitely you have to rule out cervical reticulopathy and not think as the first diagnosis having lateral and medial elbow tendinopathy. Something that is very frequent is that, like most of neuropathic pain, you will find proximal irradiation of the pain. And although it's not very frequent, but it's very indicative of this cervical pathology, is that most of the patients will have also sensitive alterations. So if you have all these findings at the same time, probably you will have to rule out first cervical radiculopathy. The second differential diagnosis that you have to take into consideration is this, the radial tunnel syndrome. The radial tunnel syndrome has a slight of a problem in the sense that patients with lateral elbow tendinopathy may have at the same time radial tunnel syndrome. This is not an entity that goes only by its own. So some patients, particularly those patients with very chronic lateral tendinopathy, say 9 or 12 months of chronicity, may also have radial tunnel syndrome as a diagnosis. And it's very important to differentiate between these two pathologies. Well, in the radial tunnel syndrome, you will also have lateral tendinous pain origin. But the difference is that the pain in the radial tunnel syndrome is found also with passive pronation that is not found in lateral tendinopathy. The pain with lateral tendinopathy is only with active pronation, not passive pronation. Also, you will have pain with a passive extension of the wrist and pain with resisted supination that is very infrequently found with lateral tendinopathy. In these patients, I use a diagnostic lidocaine injection just to rule out the presence of a concomitant radial tunnel syndrome or the radial tunnel syndrome as its own. In all of these patients that I want to rule out the presence of radial tunnel syndrome, you must have a MRI. Although it is described that patients with this entity may have findings in the EMG, in the electromyography, it's not very frequent to find definitive findings, so to speak, of compression of the radial nerve. It's not very frequent. You will have to have these dynamic EMGs that's not very easy to have, but you can have the MRI. And a very important finding in this MRI, as I'm showing here with a cursor, is to find signs of denervation of the supinator muscle. As you can see, the signal in the supinator muscle is very different to the rest of the muscle of the proximal forearm in cases of radial tunnel syndrome. You can see this slight edema around the muscle belly of the supinator that is very different in sign from the rest. You may find something in T1 images, but I will advise you to have these lysis in T2 axial cuts just to see the signs of early denervation of the supinator muscle. I also use this rule of 9 test, and it goes like this. You will make like a grid of the proximal forearm on the volar aspect of the forearm, just starting distal to the elbow crease. and you will divide in nine different sections the proximal form. This is the lateral side, and this is the medial side. The patients with radial tunnel syndrome will have pain with palpation in zones number 1 and 2 that are marked in red. When the patients have pain in zones 5 and 6, you will have to rule out a compression of the median nerve. And all the circles that are marked in blue, in this case, will be pain-free when palpated in cases of radial tunnel syndrome. And finally, in cases of this pathology, you will find weakness that is often not accompanied with pain of middle wrist and wrist of the middle finger, sorry, and wrist extension. So, as I said before, radial tunnel syndrome can go with lateral elbow tendinopathy too. So you have to take this into consideration, because very chronic patients that have some kind of treatment of lateral tendinopathy will still experience some kind of pain after the treatment, and you will have to discard the presence of a radial tunnel syndrome. Another differential diagnosis that you have to take into consideration is the radiocapitellar arthritis. It's very infrequent to find it in as a primary diagnosis. Almost all patients, if not all of them, will have the history of trauma and may have these findings in some cases of very subtle, non-displaced radial head fractures that were not recognized in the ER or when going in the first days to a orthopod office. But with time, they will develop this pain on the lateral side of the elbow. And when you have an X-ray, you will have these very specific findings. If you see, you can see on the medial side still the presence of a joint line between the coronoid and the trochlea of the distal humerus. But on the lateral side, you will see that this joint line is almost disappearing, and you will even see some kind of overlap of the radial head with the capitellum. You will have to be very careful, because if the patient is not able to fully extend the elbow when taking this AP view of the elbow, you may be somewhat concerned, because you can see the overlap of the medial joint line too. So just to rule out the presence of isolated radiocapitellar arthritis, you will have to also see in the lateral view these signs of degenerative pathology of the radiocapitellar arthritis, and this presence of osteophytes in the radial head will be very specific for this pathology. In these patients of radiocapitellar arthritis, you will have very painful pronation and supination with the elbow flex, and it doesn't matter if it is passive or active. The treatment in some cases may be the implantation of a radiocapitellar arthroplasty that is not very frequently used. And in some cases, you will argue that probably just doing the resection of the radial head will be more than enough. Another pathology that we have to take into consideration as a source of lateral elbow pain is a posterolateral plica. The posterolateral plica, just as in the knee, may be a finding that may not be necessarily pathologic. The thing with the plica is that once it is inflamed, the majority of the cases will be post-traumatic. It's very difficult to have a pain-free elbow. And the presentation of these of pain due to posterolateral plica is slightly different to pure lateral tendinopathy because it presents with lateral pain in the elbow side of the elbow, but it also is located in the posterior side of the joint. So you will have posterolateral pain. But if you palpate the posterior radiocapitellar joint line, it's going to be almost an excruciating pain. It is said that it is very painful with flexion, but in my experience, I prefer to do this impingement sign with the elbow in full supination, with the foramen in full supination, and extending the elbow while I palpate the posterior radiocapitellar joint line. In this case, the plica is going to get impinged between the distal humerus and the radial head, and that is, for me, the most pathognomonic finding of a posterolateral plica. Of course, you will also have to have some images of the MRI, and you will almost always find the presence of the plica in coronal images, like the one in the left side, and in sagittal images, you will find the presence here in the posterior radiocapitellar joint. The problem with the posterolateral plica, especially in chronic cases, is that it's going to cause also a radiocapitellar joint arthritis. So in these cases, you will have to be very careful just to rule out if the radiocapitellar arthritis is the main source of the pain or the presence of the posterolateral plica. This is a video that I use to exemplify the presence of posterolateral plica. In this case, we are going to do an arthroscopic resection of this structure, and we are located in the posterolateral compartment of the elbow. I'm going to sign. This is the posterior aspect of the capitellum. This is the sigmoid fossa, and this is the radial head from posterior. So I'm using a soft spot viewing portal in the posterior aspect of the elbow, and I'm using a accessory portal also in the posterolateral compartment of the elbow. And in this case, we are doing the whole resection of the plica, but as you can see, we can also have these very early signs of radiocapitellar arthritis due to the impingement of a posterolateral plica. And as you can see, the cartilage in the posterior capitellum is very soft. So this is also a sign of radiocapitellar arthritis secondary to an impingement with a posterolateral plica. Another differential diagnosis that you have to take into consideration is the posterolateral rotatory instability, particularly those very subtle cases in which the patients have the history of dislocation. We know that the most frequent dislocation is a posterolateral dislocation of the elbow. And in some cases, due to very early and aggressive rehab or just to inadequate immobilization after the dislocation, we can have an insufficient healing of the posterolateral ligament complex. So in these cases, the patient may have residual lateral elbow pain, but due to posterolateral rotatory instability. So it's very important to have to know if the patient has any history of dislocation. Some patients, particularly those patients with the history of pediatric distal humerus fracture that may have residual cubitus varus, may also have very subtle signs of posterolateral rotatory instability. Those athletes that require full extension for their sport may also have extension overuse of the lateral ligament complex of the elbow, and may have also very subtle signs of this rotatory instability. And although it is described that these patients may have a pivot shift test positive of the elbow, it's not very frequent because it is so painful that it's not very easy to do this maneuver in the office. almost all of my patients will have a pivot shift only under anesthesia. And in this case, we have to take into consideration if we have to reconstruct the LUCL or just repair it. I've gone through different phases in my professional career. First, I began doing the reconstruction, then I shifted to doing only repair. Then I came back to doing reconstruction because of some residual cases. And right now I have go back again to doing primary repair, but including the posterolateral capsule that I think it's also a very important stabilizing structure of the posterolateral elbow. The patients with posterolateral elbow in the MRI will have very specific findings. We know that the elbow in this kind of instability is going to be unstable with the elbow in full flexion. With full extension and supination of the forearm. That is the position that the patient has to keep during an MRI exam. Most of the patients that go through an MRI for this pathology are not going to be able to go through the MRI because it's going to be very painful and very uncomfortable. And this is the reason. The patients will have this posterior subluxation of the radial head, and they will have to go with the arm in pronation just to have a recentering of the arm. But if the patients are willing to go this exam, going first the first sagittal slices with the elbow in supination and then doing the forearm in pronation, you will have these two very significant images that are going to confirm the presence of a posterolateral rotatory instability. I always try to explain to my patients what we are going to experience with the exam and the relevance and importance of these findings. And the final differential diagnosis that we have to take into consideration is a lateral antebrachial cutaneous nerve compression or irritation. It is a differential diagnosis that I am seeing more and more at my office, and we have to be very careful because it presents almost identical to lateral elbow tendinopathy. The difference is that these patients have very painful palpation in a point that is located 5 centimeters or 2 inches proximal to the epicondyle. The patients with pure lateral tendinopathy do not have any reason to be painful if palpated at this point, but the patients with lateral antebrachial cutaneous nerve compression or irritation will. What I do in all of these patients is to go through a lidocaine diagnostic testing. And what I do is to mark my lateral epicondyle, then I will go 2 inches proximal to the elbow and just infiltrate about 3 cc's of lidocaine, and almost immediately the pain is gone. This is a very important differential diagnosis that has to be kept in mind in patients that have gone through a surgery of lateral tendinopathy and they still experience pain, because particularly in very chronic cases, some patients may have this pain that is still located in the lateral elbow, but also the difference is that it is irradiated proximally about 2 inches. In these cases, in these refractory cases, I will go through a neurectomy of this nerve. Fortunately, I have not had a case of a subsequent painful neuroma of this nerve, and it is a very effective procedure, particularly in these refractory cases of lateral elbow pain. So I did not want to go very deep into all the diagnoses, but I want to have this very general overview of all the causes that will explain the presence of lateral elbow pain. And I just want to say goodbye with these two thoughts, that the lateral tendinopathy is still the most frequent etiology of lateral elbow pain. But there is much more to lateral elbow pain than only this lateral elbow tendinopathy. And thank you very much for this invitation. And I hope there is some opportunity in the future to share with you this time and space. Thank you.
Thank you, Dr. Rui. That was a fantastic presentation. You have covered the entire spectrum of lateral elbow pain, looking into the differential diagnosis in detail. There are a couple of questions that have come up. I'll just go through some of those.
Yes.
One is to identify a radial tunnel syndrome. Basically, you're looking at an entrapment neuropathy of the posterior interosseous nerve, isn't it?
That's right, yes.
And so if there is a tenderness, say 3 finger breadth distal to the lateral epicondyle, isn't that a good sign? And what other signs do you look along with that to come to a diagnosis of radial tunnel syndrome?
Well, first, the nature of the pain is slightly different because it is a neuropathic pain. So the patients will experience this very uncomfortable sensation through the lateral aspect, and they will very frequently say that they don't even that even the clothes are very uncomfortable to wear. And this lidocaine test that I infiltrate the radial nerve distal will disappear almost always the pain at this point, but in some cases, or most of the cases, the lateral elbow pain due to tendinopathy will still remain. So for me, it's a very important test to do this lidocaine test, and the type of neuropathic pain will also give us some clue on the radial tunnel syndrome.
The other one is a very common mnemonic that we use. It's, I don't remember whether you mentioned the FREAS, F-R-E-A-S, looking at fibrous bands, radial recurrent leisure Henry, the extensor radialis brevis, the arcade of Rossi, and the supinator. So all of these, how do you really differentiate which is really causing the pain? Because there are 5 very important, and in additional, you have mentioned a lot of other causes as well.
Yes, I think most of the patients will have these MRI findings, and these very identifiable cause due to the supinator. You will have in the MRI this denervation sign of the supinator in the MRI. It's not very frequent, at least in my experience, to have a refractory case to any of the other causes that you have already mentioned, although you have to take that into consideration because they are also a differential diagnosis to this radial tunnel syndrome. Because in addition to the points you mentioned, we have 5 more additional causes, so that becomes a big spectrum. Yes, definitely. And you have added lateral antebrachial cutaneous nerve as well. Yes. So that's going to be a really big end to, and I think that's the reason when you look at patients that does not respond to surgery, I mean, most of them have fallen into these particular groups. Yes, and it's unfortunately, well, my practice is much more focused to shoulder and elbow. So I think my practice is a little bit biased, and I see a lot of these refractory cases. But I've seen that a lot of these refractory cases will also have this proximal pain in the lateral aspect of the elbow, and doing this diagnostic test to see if it's the sensitive branch, say the lateral antebrachial cutaneous nerve, will be a cause of lateral pain in these refractory cases. So you need a lot of clinical acumen to make a diagnosis. You need to use the injection wisely. I think that is a very important takeaway point, that we need to use the injection wisely to find out exactly where the pain comes from. That's right. That's right. And the other one is regarding posterolateral instability. The test that is described as a posterolateral instability test that you look at in flexion, I mean in extension initially. Extension. Varus force, and then gradually you flex,
and then you can feel the subluxation of the radial head posteriorly. Am I right?
You're right, although that is not very frequent because the patients will automatically stop from doing this full extension, but because it is going to be a very painful experience. So what I'm doing now is doing what is called the tabletop test. So it is like doing like a push-up, but you have to place your forearms in full supination and with sitting in a chair that has this armrest, you will have to go like this.
Yeah, like that. Okay.
And the patients.
It's called as a chair test, isn't it? Chair test.
The chair test and the tabletop is doing this like almost push-up exercise with a supination. And when the patients go with the elbow flex, they don't have any signs, any symptoms. But when they are going through full extension, they are going to avoid this full extension because it is very painful or very uncomfortable. What I would do is then ask to go again to the flex position in the tabletop test. And with my thumb, I'm going to push from posterior the radial head like I was like I am stabilizing and the LUCL, and then the patients are able to go through full extension without any problem.
I think it's very similar to the pivot shift of the knee, isn't it? Very closely.
Yeah, very, very similar. The only difference is that in the knee, when you do this with this pivot, you will see that this is the rotatory signs of instability, and in the elbow, yes, and in the elbow, in the office, it's going to be almost impossible to do because it is very uncomfortable. If you do this maneuver under anesthesia, you will almost always find it.
Okay, so in an extended position, it's usually reduced, and as you grow, I mean, go into slight flexion, it subluxates, and when you go into complete flexion, it relocates, is it?
That's right, yes. Well, flexion and pronation, both.
Flexion and pronation relocate.
Flexion and pronation.
Yeah, it's the same thing with the knee as well, because it's very difficult to elicit a pivot shift in a normal patient unless you're anesthetized. I mean, I do ACL reconstruction and I know the difference, because unless the patient is anesthetized, it is extremely difficult to do.
Yes, that's right. That's right.
Okay, and something regarding the tennis elbow. We know all those three tests, like there's a Cousins test, there's a Mills Maneuver, and also the Maudsley's test, which is nothing but a resisted middle finger extension test. Am I right?
That's right, yes.
I mean, a lot of studies that looked and they found that the Maudsley's test is one of the most sensitive tests. Do you agree to that?
Yes, but particularly in the very acute cases, because in these very chronic cases, the Maudsley test is going to be definitely by far the most indicative of the lateral elbow tendinopathy, but the pain is going to be located much more diffuse than only in the very specific point of the ECRB origin.
And I know we have just gone into the diagnostic part of the lateral elbow pain, but since we have gone this far, can you just approach how do you, once you've made a diagnosis of tennis elbow, that is the pain originating from ECRB, then how do you really treat them?
That's a tough question. To be honest, I still do a lot of steroid injections, and I've had excellent results. I've gone through different phases through my practice. I've gone through arthroscopic release with good results, not excellent, good results. I've gone through open release and tenodesis of the rest of the tendons, good results, not excellent. PRP, leukocyte rich PRP with good results, not excellent. Eccentric strengthening, good results, not excellent. And what is much more consistent with good to excellent results is still this steroid injection.
Okay, I think that's a very important takeaway point, because you have gone through the entire gamut of, I mean,
yes,
and finally that steroid is one of the best choices for treatment of lateral epicondylitis, or if you
Definitely. Yes.
diagnose of the pain originating from the ECRB and the related tendons.
That's right.
I think that, thank you so much, Dr. Michell. I mean, that has been a fantastic presentation, and it is a great
Thank you.
honor for us to have you on board, and you being the president of an important organization, the message is very, very strong. Thank you so much for being with us, and we look forward for some more presentations from your side.
Definitely. Thank you. I'm waiting for another invitation. And thank you. It was an honor, a truly honor. Thank you very much.